everybody, and welcome to today's webinar. We appreciate you taking the time to join us. I have the honor of presenting Dr. Luis Zayas, who is a longtime collaborator of the National Hispanic and Latino Mental Health TTC. Dr. Zayas is the Dean Professor and the Robert Lee Sutherland Chair in Mental Health and Social Policy in the Steve Hicks School of Social Work and Professor of Psychiatry at the Dell Medical School of the University of Texas at Austin. In addition to numerous papers in scientific journals, Dr. Zayas is the author of Latinas Attempting Suicide When Cultures, Families, and Daughters Collide, and Forgotten Citizens, Deportation, Children, and the Making of American Exiles and Orphans. So, Dr. Zayas is our presenter, and now we'll begin our poll questioning so that we can get to know our audience. First question. Do you currently serve Hispanic and Latino populations with mental health disorders or with serious emotional disturbance? So 83% of our participants say yes, 17% no. Are you planning to serve Hispanic and Latino populations in the next 6 months? %92 of our participants say yes, 1% no, 8% don't know. What is your current professional role? And we have 25% social worker, case manager, 44% counselor, therapist, or psychologist or nurse, 10% faculty research student, 5% government, and 18% other. What type of setting do you currently work in? Okay, we have 16% university higher education institution, 31% treatment, 12% government, 42% other. So now we'll begin our pre-test. Of all adolescents, male and female, Latinas have the highest rate of suicide of any group. True or false? %65% of our participants say true, 34% false. Which of the following is not a major factor in the suicide attempts of Latina adolescents? Okay, 24% family adaptability and cohesiveness, 37% the way Latinos raise and socialize, 29% the peer group, 9% the impact of immigration and acculturation. And our last question, to prevent suicide attempts among Latinas, psychoeducational groups of middle school girls for parents separately are indicated. True or false? %66 say true, 35% say false. Okay. So thank you for answering our questions. I will now leave you with our presenter, Dr. Zayas.
Thank you very much for the introduction, and good morning or good afternoon to the participants today. Thank you very much for being here, and I'm really always pleased to be able to talk about something that has been of concern to me for decades, and a chance to share what we know, and hope that it will enhance your practice, your teaching, your research. And so what I want to do today is cover in broad strokes the suicide attempts of young Latinas and where we are and what we need to know more, but also some ideas about intervention, particularly for the clinicians and for those of you who teach students in any of the disciplines in practice, whether it's nursing, social work, psychology, psychiatry, and so on. First slide, please. Next slide. Okay, well, go back one, I'm sorry, we're there. So what I want to do is cover some of the background on suicide attempts of young Latinas, talk about some theoretical and empirical perspectives, and then talk about cultural and social hypotheses that we do know about this group, and then talk about implications for services and therapies. Next. This is what the past 30 years of surveys by the Centers for Disease Control and Prevention show, that indeed young Latinas are have the highest rate of suicide attempts of any group, which goes to that first question. 65% of you said it's true, and indeed it is true, that they tend to attempt suicide more than any other group of girls, perhaps with the exception of American Indian or Native Americans on reservations and off reservations. The only time it's really changed this pattern was in 2017, 2 years ago, when we saw that there was an increase in the number of African American girls who had attempted suicide compared to the others. But as you see in this graph, we go back to 1995 or so. That's when the highest rate was registered of the suicide attempt. One in five girls, Hispanic girls, was attempting suicide, and this is across all Hispanic subgroups and across all regions of the country. So you get to see that for those of us who have been worried about this since the early 1980s, the problem persists, and it's something that we need to continue to attend to. And webinars like this one are important to have as often as we can to disseminate this information. Next slide. These are the figures from 2017, and I might just add that the Center for Disease Controls and Prevention's survey, the Youth Risk Behavior Surveillance System, occurs every other year. The data are collected in odd numbered years, and they're released the year after they clean it. So they arrive in the even numbered years. So for last year, the 2019 data, those are not out yet. They will probably be released sometime this June. So I'm working from 2017. And what we saw here, or rather what we see in this chart, is something that all of you will know, that oftentimes suicide attempts begin with, there's a progression. They begin with a sense of sadness and hopelessness. And in this chart, you see that young Latinas are more likely to experience sadness and hopelessness than other groups, almost registering 45, 47% of them reported on the survey that they had felt that way. And it's interesting because both among males and females, the same was true for the Hispanic group. And you'll see some of that as we go on. Next slide, please. So from sadness, we begin to have young people begin to think or ideate about suicide. And here they're seriously considering suicide. And in this case, in 2017, that's when Hispanic girls and African American girls were about average. The African American adolescents were slightly higher. Interestingly, though, when you join the male and the female for that year, then we really have the white youth as seriously considering suicide than other groups. Next slide, please. Now, of course, when you think about it, you then think about, or a teenager will think about a suicide plan. And here again, we have an interesting finding that in 2017, the African American girls had higher suicide planning than Hispanic girls, although for the prior 18 or so surveys, the case was that the Latinas were much higher on this as well. Next slide. And then culminating in the progression culminates in a suicide attempt. And again, in 2017, African American girls had higher rates. But as I mentioned before, that was the first and only time that has been the case. And we'll see what happened in 2019. We can do a lot of, looking at social events in our midst that will lead to these numbers. And we know that in the past few years, our country has been going through an awful lot with both the political changes as well as the kind of everyday news we get about African Americans and the issues that face them, the challenges and the institutional racism that faces them every day. So we can imagine that this particular year may have been affected by those public events. Next slide, please. So we can, again, following this, we're still pretty much going along the same route. It's a different way of presenting what I've just presented, that the suicide attempts in 2017 were higher for African Americans than for Latinas, but Latinas have historically had higher rates. It's also interesting too that when the survey asks, did you need medical attention for your suicide attempt, Latinas and African American girls are more likely to have required medical attention, which means the severity of their attempts were greater than others. Next slide, please. And this is just to give you a progression. I'm looking here at some of the core Hispanic states. There are some states that have high representations of Hispanics that are not represented here. In this case, California and New Jersey were not studied in 2009. But this gives you a sense of where Hispanic girls were in those states. And you can see Arizona, Colorado, Florida, Illinois, must be New Mexico here, sorry, and New York, Texas, were much higher among Latinas than others. And in Puerto Rico, the case has been that they're approaching 20%. Next slide, please. 2 years later, we continue to see the same progression. And we have here, in this case, New Jersey data is available as well as New Mexico, but you see Latinas are consistently reporting higher rates in these Hispanic dense states. We probably are going to be seeing the same thing in states where they're newly populated by Hispanics, the mid-Atlantic states, and the Carolinas, and other states where they have historically not had a large presence of Hispanics. Next slide. When we move to 2013, the same pattern occurs, where we do have a consistent number of Latinas attempting suicide. So next slide, please. This is 2015. Now here I put the figures, but this is to show that while in 2017 we've had a switch where the African American youth are showing higher rates of suicide attempts, across time the Latinas have always been more likely to attempt suicide. Now let me just take a moment to point out here that typically the data are released by the Centers for Disease Control in about June of the summer. So this summer we will have that. What happens is within the first 3 to 6 weeks of the data being released, the press goes after this, and they make a lot of hay on this. They'll report on the local evening news and your newspapers about how Latinas are attempting suicide more often than others. but then it subsides. Then that attention subsides. And that may be one of the reasons we have a continued lack of attention and understanding of the suicide attempts of young Hispanic females, and why we need to pay more attention to it. But it does go away, and I think what we need is much more consistent attention. Next slide, please. And I want to just point out that it's not a new phenomenon. It really dates back to the 1950s. So I will share a little bit about my own professional history. Starting out as a social worker in New York City in the 1970s, mid-1970s, we began to see in the clinics lots of young Latinas attempting suicide. Now, if you think back, for those of you who know something about New York in the 1970s, the majority of those would have been Puerto Rican girls. In the 1980s, we began to see more diversity and many more Dominican girls entering, Dominicans being seen in New York City. And so at first it was, what we were seeing in the emergency rooms were Puerto Rican girls. So we thought, is this a Puerto Rican phenomenon? And then later on, we began to see it happening also among the Dominican girls. I learned later that in Miami, Cuban and Nicaraguan girls were also attempting suicide at higher rates than any other groups. And at one point, there was a paper published from Southern California also indicating that there, the Latinas too were more likely to attempt suicide and would appear in hospitals more frequently for suicide attempts and for any other disorder. And so I went back to the literature when I began to see this, and the only thing I could find were two papers published in 1961 by Edgar Troutman. And he called it the suicidal fit, and he had studied women in the South Bronx. His report showed that most of the attempts were impulsive escapes from stressful situations. The typical mode was to ingest pills or drink some household cleanser. More often than not, it was a problem in some family relation, more likely to be around a spouse, boyfriend, or a mother. The women reported to Troutman that they had no thought of death. They weren't really intending to die, but they were not aware of their thoughts at the time. The clinical diagnoses by Troutman of all his subjects indicated that none of them had any psychotic symptoms. So he called it the suicide fit, a momentary lapse in acknowledgement of death or their thoughts, and the attempt came about. If we were to stop this seminar now, that's what we would still find today. But I don't want the seminar, the webinar to end now, so I'm going to go ahead and break all of this down for you. But let's remember those points. Next slide, please. So what do we know in general about youth suicide attempts? We know that they demonstrate some cognitive, emotional vulnerability, whether it's hopelessness, like in the earlier slides, emotional pain, feeling a sense of worthlessness, of course, depression, which is the precursor for many suicide attempts. Many of the young people have poor coping skills and strategies. They tend to withdraw, and they cope by avoiding interaction with others or engagement. Again, something that we associate with depression very commonly. Among those who attempt, there's not a really, they perceive themselves as not having strong social connections, whether it's the family, friends, or others. And whether that lack of social connection is perceived or real, or whether it's internal, external, that is the feeling, that does add to their chances of a suicide attempt. And we often see the sudden changes in their social network, oftentimes associated with the loss of an important person in their lives. And of course, there's the acquired capability. That is, a youngster who's thinking about suicide and attempts it will engage in high-risk behaviors. It's a way for them to begin to manage and to even think about the possibility of taking their lives and what it would be like. And they often do engage in some form of violence against themselves through self-cutting and things like that, or against others, getting into fights at school, and things like that. So those are some of the general reasons we understand youth attempt suicide. Next slide, please. We do know that, well, I'm sorry, this is DSM-4. I know we're on 5, and I should say 5 there. But we do know that nearly all DSM disorders have some connection to suicide attempts, to the subsequent suicide attempt. The highest risk for suicide attempt is someone who has suffered from some form of PTSD, and that's a high risk. Dysthymia, of course, and anxiety. All of these go in together. So if you have a diagnosis of one or more DSM disorders, the risk continues to increase for a first-time suicide attempt. So those of you who are working with young people in clinics, you want to look at that carefully and make sure that you get some idea of the possibility and the probability that this child might attempt suicide. And there are comorbid diagnoses. There's a sevenfold, when you have more than 2 diagnoses, you've got a greater likelihood of a suicide attempt, and the same as the disorders that you diagnose amass. Next slide, please. We need to look at cognitive processes in the suicide attempts. Impulsivity is the first one. And it really more perhaps is made of it in some ways than needs to be the case. But impulsivity is important. It's a moderate risk factor for suicide thoughts and behaviors. Now, the difference between a state and a trait is where we need to make some distinctions. When it's a state, impulsive state, it might not lead to a suicide attempt. But when it's a trait that the person possesses, that is, impulsivity is a trait, that will likely predict the suicide ideation and the suicide attempt. So if the child has a trait in which they tend to be impulsive, the likelihood of a suicide attempt and death by suicide is likely, even if the child did not want to die, but that impulsivity may have driven them to suicide. And we do know that cross-sectional findings support the role of the cognitive process, information processing. They show deficits in attention and vigilance compared to kids with no lifetime experience of suicide attempts. Next slide, please. Of course, there are the emotional, the affective processes. As I mentioned earlier, worthlessness, low self-esteem increases the risk, even when we control for depression. Anhedonia, emotional dysregulation, have also been shown to increase the risk for suicide attempts. And we know that emotional dysregulation can be a result of childhood trauma, abuse, neglect, and that those early years when the brain is forming and the wiring for emotional regulation, cognition, social interaction, all are built. And then the hopelessness can be mixed. It has occasionally been seen to predict suicide behaviors, but it's not always the case. It's considered a distal factor rather than a near factor, a proximal factor. Next slide, please. So as I mentioned, we have to think about the childhood experience. What are the childhood adversities that the child has faced and predict? We do know something about adverse childhood experiences, ACEs, and these predict a lot in the way of both psychopathology but physical health implications. And we do know that the more adversities, the likelier it is that there would be some suicidal behavior. So, for example, 2 to 5 times the increased risk for suicide attempts when children have those early childhood adversities. And the child abuse is one of the adversities that's most present. And I think we've got to remember that. When we set out to do our study, one which I'll talk to you in a minute, we had not really taken into account to ask questions about that. But the girls that we studied told us themselves. Next slide, please. Now, continuing this kind of generic, if you will, or general representation of suicide attempts, we do know this. We know that there are underlying reasons for the attempt. That is, the circumstances that a teenager says she struggled over a long period of time. Family dysfunction is a big factor, and that's the most often reported underlying reason for an attempt. Conflicts among family members, not just the entire family having dysfunction, but conflict with an older sibling or a parent are more likely to be an underlying factor, as well as drinking problems either by the girl herself in this case or by members of the family, especially a parent, will be one of the underlying reasons. And of course, anytime there's sexual abuse or molestation, these are some of the underlying reasons that typically are given by adolescents for why they attempted suicide. Next slide. In the next slide, we will see that then the other factor is the trigger. So you've got this propensity, right? Underneath you or underlying your attempt, there's stuff going on. There's alcohol abuse, perhaps some abuse in your life, conflict with an older sibling, a younger sibling, someone who perhaps the young person sees as being favored by the parents, or perhaps feeling neglected or rejected by the parents. Those are the sorts of things that give the underlying setting. But then there's that moment. It's like anything else, you know, the more wood you have in a fire, the likelier you are to ignite it. And so the trigger event occurs in the girls that we studied shortly before the suicide attempt. The girl says that there was something that really bothered her. The most common report was that there was a relational conflict with a family member or a sweetheart, a same-sex partner or opposite-sex partner, a friend or other close person. And these are some of the triggers that Latinas have historically told us, both in clinical and in research settings. And that the emotional experience that they had just at the moment of the attempt was that they couldn't deal with all of these complex feelings. And if you remember before, the issue of coping strategy skills are so important when you have a child who has got all these mixed feelings and their coping skills and their cognitive processing is not well developed. They will succumb to these to the emotional experience, and they'll experience this escalation of frustration and tension that leads to the suicide attempt. Let's go to the next slide, please. So this is the model that I drew up many years ago in the early 70s. We published it sometime, I think, in 2000 something. But this is what, based on clinical experience and research, my team and I came up with this model. That when we have, that is this model to explain why Latinas have a higher likelihood of suicide attempts and what will distinguish one Latina from another, is that we have the family socio-cultural environment that's made up of three things. That's the adolescent's own development and issues of the developmental needs for autonomy and identity and things like that. We'll return to that in a minute. Then there's the family function. How well does this family function as a family and responsiveness to one another and to their growing children? Then we have to take into account the cultural traditions. What is it that the parents are holding on to from their original culture that help or don't help in the family's functioning, the way they raise their child, and of course the way they socialize their children, distinguishing, say, between the male socialization and female socialization. So in that context, in that environment, we see the development of either an emotional vulnerability or invulnerability. If that environment is healthy, then she's not likely to feel that vulnerable. But let's assume for a moment that there are this unevenness in the environment. It may lead her to be emotionally fragile. Then there's that interpersonal trigger, that interpersonal conflict at the moment, and then how the girl experiences that the subjective experience of that crisis leads to that frustration, the tension, and the attempt. So this is the visual for some of the things I've said before and that I'll talk about next. Please, next slide. So remember, one of the things in that model is the developmental. And so we've operated, and I think it's useful for us as we grow in our understanding of human development and theoretical perspectives. is to think about the developmental systems theory, how people develop. We do know that there's a reciprocal interaction between the person and the environment. It's not simply that the environment affects us, we too affect our environment. And so that's one approach. The other is that we have to look at ecological systems, the person within their environment, within their the immediate environment of their family, what's outside and what's large and beyond our control. And Yuri Bronfenbrenner was important in that. And then I draw on the work of Lev Vygotsky, the Russian psychologist, who talked about the zone of proximal development. And Vygotsky's point is that there's an intimate interaction between the parent, the child, and first in the context of a home, before the child even steps outside and begins to enlarge their social circle and their experience of the world. That in the interaction, early interaction, we see that how culture is transferred to children, how they learn about how they can regulate their thoughts. Regulate their feelings, which feelings are acceptable, which are not. All of this surrounding culture is so important. And the reason I like Vygotsky's work is because it takes us to the very micro of a family and the interaction within a family and between child and parent. Next slide. And so when we use that, we move to adolescent development, and we can use two key elements in the development of adolescence. Their movement towards greater autonomy. I want to think for myself. I want to have my own feelings, and I want to act the way I want to act, not dictated by the family. And that's part of the development, which most of you will know from your own adolescences, as well as your children and your clients' development. But at the same time, the child wants to remain connected. That adolescent wants to remain connected. So while they want to be free and autonomous beings, they also want to have some help from mom and dad. Remain connected, because that's a sense of belonging in your family, especially when the outside world gets troubling. There's a book out there somewhere, I don't recall the exact title, but it runs something like this that I think really embodies this idea. And that is, the book is titled something like, "I hate you, but please take me to the mall first," or something like that. And that's a sense of that struggle between autonomy and relatedness and the need for connection to parents. Next slide, please. We think about family systems theory. Now that gets to the issue of how well functioning that family is in that family sociocultural environment that was in the graph. We do know from family systems theories that families deal with two levels primarily, or two activities: how cohesive they are, but how flexible and adaptive they are, right? And parents have to make, or families have to adjust those. They want to remain as a family unit. We know about external boundaries, internal boundaries. They want to remain a cohesive unit, but they also have to adapt to the world as well as to the development of their children. A parent will not respond to a 15-year-old the way they do a 5-year-old. They have to allow for that 15-year-old who is now more physically mature, cognitively advanced, engaging in social activities, and having much greater independence. But how do you maintain that cohesiveness and giving the child a level of flexibility in order to move out into the world and prepare for the assumption of adult roles? And it's, when you have high on cohesiveness and high on adaptability, your family's doing well. When you have too much cohesion and not enough adaptability, then we might be more enmeshed as a family. When you have too much adaptability and no cohesion, then you've got this more disengaged family and perhaps more permissiveness, where a person doesn't feel necessarily connected because they're much more engaged with the outside world. So it's really that balance. And of course, fundamental to any of this is communication. How it is that the family communicates, listens to one another, and not just listens in a cognitive sense, but empathizes and understands the other person's feelings and experiences. Next slide, please. Cultural psychology is something that we need to look at. We do know that culture determines the variations in the family structures and interactions, how they rear their children. Culture provides us the context and the rules for how families will interact and how children will interact with their adults, how close they will remain to their family, what's expected of them. So we have to remember that culture too influences that, and it sets the limits of emotional tolerance. You know, what we can express and not express. So in the DSM, we know that in the back there's the glossary of culture-bound syndromes. That comes from that the vocabulary or the of a culture about how emotions of different kinds are displayed in that particular culture. Next slide, please. So as I said, this is more of the same. Culture shapes, you know, how we think illnesses or problems emerge, and how that experience, that illness can be expressed, what the symptoms are. In many Hispanic cultures, we have the term the nervios, you know, the nerves, which is one way of expressing emotional distress that makes it perhaps less stigmatizing than to say I've got a depression or I've got a problem that implies some kind of mental illness. Next slide, please. So we did a project. I'm going to run through these because I don't want to bore you with the details of the study. But we did a study in which we interviewed 122 girls who had attempted suicide. They were all drawn from mental health clinics, 88 of their mothers and 19 of their fathers. We compared those to 110 non-attempters from the same zip codes and neighborhoods, 83 of their moms and 17 of their dads. The whole sample was at the average age was about 15, which is actually the prime age for a suicide attempt, the first suicide attempt, particularly. Although it's not to say it's the only time, but it is in general what children report or what we do know about suicide attempts in kids. And in our group, they were 15 years old on average, and the parents' average education was about 10th, 11th grade. We were seeing some kids who were already more advanced educationally than their parents. So that also adds to some of the interaction or the interactional problems with parents. Next slide, please. I beg your pardon, go back, I'm sorry. So we asked ourselves, you know, why do some Latinas attempt suicide while girls that look just like them don't attempt suicide? And then we wanted to look at not just why one attempts and the other doesn't, but what are the elements of the suicide attempt? And I'm trying to go through those. Please, go ahead, next slide. We found that familism that parent-adolescent conflict was higher among the attempters than the non-attempters, nothing that would be surprising, and that attempters showed more internalizing problems, depression, things like that, than non-attempters, and that attempters, or rather non-attempters, had higher self-esteem. This is just showing you from our statistics that indeed they were different populations with respect to some of the psychosocial issues that we study. Next slide, please. So I'm going to jump to the results. We found that the girls in both the attempters and non-attempters were equally more acculturated, that is, they were equally acculturated and more acculturated than their parents. Again, it's like stating the obvious. Kids acculturate more rapidly than their parents do. In all immigrant groups, not just Latinos, but certainly in the case of Hispanics. We found that when we measured familismo or familism, the tendency to be centered around the family, the cohesiveness of a family, the importance of the family in the Hispanic culture, we found that teenagers, the girls on both sides, were less familistic than their parents. The parents said, oh, you've got to tend more to your family, you've got to be here more, don't go away, you know, holidays should be spent with families, things like that. And the kids were saying, no, I really want to be freer and get away. So that didn't differ. Again, the girls were less familistic, less than their parents, but more acculturated. What now is when we get to the next one, when affection, communication, and support were examined, the attempters reported that they had far less affection, communication, and support from their parents than did the non-attempters. And also the attempters rated their mother's affection, communication, and support significantly lower, much lower than the non-attempters rated their mothers. So these are the girls' ratings of their mothers, that the attempters rated their mothers much lower in affection, communication, and support than the non-attempters. Before you ask about the fathers, because we only had 19 fathers in one group, 17 in others, we didn't have statistical strength, power in order to be able to answer those. So I want to make sure that you understand that these were the findings where we could report higher levels of confidence because we had the statistics, statistical power. Next slide, please. Now, here's where we began to see real differences. When we talked about this reciprocity between mother and daughter, we asked both the mothers to talk about themselves or answer questions about themselves and their daughter's relationship. And then the girls talked about their own relationships and reactions to their mothers and what they thought their mothers were, how their mothers were reciprocating or not with them. So it's an interesting dynamic. I'm telling you how I feel about my mother, and I'm also telling you what I think my mother does or feels. And here the attempters said they were much lower in mutuality with their moms than the non-attempters. So they were saying, oh, my mom doesn't reciprocate. She really doesn't understand me. Where the non-attempters are saying, yeah, my mom understands me. Not great, but better. And that's in that next line where the girls in general, both sides, and you can understand that teenagers would always say, my parent doesn't understand me. Well, the attempters were more likely to say, my parents really don't understand me, whereas the non-attempters would say, they don't understand me. And there was a gap between those. The gap between the attempters and their moms was greater than the gap between non-attempters and their mom. Now, it's interesting because when we asked the mothers, they felt very connected to their daughters. They felt very attuned. They knew their daughters' feelings, their moods, their thoughts, their emotions, all sorts of things. But the girls had a different take on it. And this is where we begin to see how one group of Latinas differs from the other. The attempters disagreed with their mother's perception. They thought, my mother is not attuned. She doesn't get me at all. She doesn't understand me. And on the other hand, the non-attempters were saying, my mother doesn't understand me, but she does somewhat, and at the very least she tries. I know that she doesn't really get me, but I like the fact that she tries to understand me, even if she thinks so, I humor her, but at least I do know that I've got her affection, her support, her communication. She tries, though she doesn't really get it, and she's not necessarily so attuned to me as she thinks she is. Next slide, please. And why does this matter? This is why social science is great. We get to prove the obvious. We know that if two people have better communication, they're apt to get along better, and it reduces problems between them and perhaps in each of them individually. And so we found that in the 1-point increase in the measure that we use for mutuality and reciprocity, there was a 57% decrease chance of a suicide attempt. In short, the better the communication that you as a therapist or as an educator instill in a mom and her daughter, the less likelihood that the girl will attempt suicide. And I would dare say that would occur with other problems such as alcohol and substance abuse, pregnancies, and other problems that teenagers get themselves into. So that's why it's important as therapists that we get people into the room. And when we talk about reciprocity, they each share their sides of the story. Next slide, please. As I mentioned, we had insufficient data on the fathers. The girls sometimes felt that their fathers were far more understanding of them than they were. But then again, fathers weren't there because they were working, or they were away, or they were divorced fathers, or some of them imprisoned. And they could easily tell their daughters, oh, I love you. You're the best thing in the world. Oh, I understand. But it was 1 hour a week. And the rest of the week, mom had to deal with the girls, especially during those bad hair days and problems in getting to school and doing chores around the house and things like that. So they gave their fathers a pass when mothers had to carry the brunt of raising their daughters. Next slide, please. So now we got these underlying reasons. There's a crisis event or a trigger where there's this prolonged tension between girls and her parents. More often, it's about the relationships with the divorced parents. Maybe the mom has remarried, the dad has remarried. They argue around household chores. The parents are on her case about breaking rules. and maybe she's being favored, or she perceives that one of her siblings is more loved than she is, or they're getting some favoritism. Another trigger is often about the boyfriend. There was a breakup, something about dating and sexuality. But I think it's important here that this is not about boyfriend, dating, or sexuality. It's really a developmental struggle for autonomy. I want to be my own woman. I want to think for myself, feel for myself, do whatever I want, and not have to be told what to do, what to feel, and how to behave. So, and many of the triggers that we learned about had to do with privacy and boundaries that parents violated, romantic relationships that they had that parents were opposed to, or the parents wanting them to dress differently, perhaps less provocatively, longer skirts rather than shorter skirts. And just before that, there was this intense argument with the parents that triggered the suicide attempt. And many of the girls told us that one of the things that they worried about is that the conflict that they were having with their parents was tearing apart the family, and that it was really weakening the family's strength and integrity and unity, and perhaps by not being there, the family would do better without them. Next slide, please. So when we asked the girls, what did you mean? What was the meaning of the suicide attempt? We got 4 general themes. One was self-punishment and self-blame. So these are 2 quotes from the 100 and some girls that we studied. I was thinking, oh, I should just kill myself. I'm not worth it. Another one said, I wanted to kill myself. I didn't want to cause any more problems on her family. I felt so bad for everything. Then there was the emotional release part. We heard girls say, I have so much pain inside. It's kind of like I cry inside. I guess that when I cut myself, she had attempted suicide with a razor blade. I feel like I'm letting endless words out or something through the blade. I'm taking out my pain, which of course, those of you who know something about cutting, there's that element there as well. In this case, it was suicide attempts. Then there was revenge. I wanted to get back at my parents or whoever had harmed me. This girl said, I went to rub it in my mom's face. I was like, that's why I went into the bathroom and swallowed the bottle of pills. And it was a 13-year-old who took 11 Tylenol pills with codeine, and of course was taken to the emergency room. And then there was the control. It was like a breath of fresh air, this girl said, because it's like my mom wasn't the one who was hurting me. Like she didn't have control over me. She couldn't hurt me. I was in control. Again, when we talk about autonomy, the girl wanting control for herself. Next slide, please. If we move to intervention, we've got to think about how we intervene. In the pre-suicide attempt, when we're looking at that socio-cultural environment that I mentioned, and then the teen's own psychosocial function, the emotional vulnerability, if we're able to get them into our clinics because they're depressed or because the teacher says, something's wrong with her or him, why don't you talk to him? I think a lot of the work of the clinician to prevent is to try to understand what the struggles are in the child's development, how the families function, and what are the traditions that family keep in their home, and what they're instilling or imposing on their children. And then, of course, how vulnerable, how likely is it that this child would attempt suicide? Of course, there's the crisis intervention that we all know, which is the sad part, because by that time she's either attempted in a harsh way where there's injury, or she's made an attempt that's enough to draw attention to us. And then, of course, there's the post-suicide attempt intervention, which is typically, we see them at the OR, in pediatrics, we have them in outpatient mental health clinics, maybe counseling at the school if there's a school-based mental health program. Then we're talking about a retrospective on what happened and how we can prevent future. And in across that arc of pre-suicide and post-suicide attempt, I think we're really talking about communication and strengthening family connections associated with cohesiveness and adaptability. Next slide, please. Our targets of intervention, as I mentioned, this is again stating pretty much what I mentioned, how well the family is functioning. We need to do family intervention to improve the functioning, to enhance adaptability and cohesiveness. We want to understand, with parents, why, about their children, trying to help them understand their children's program. By the way, to the second question, which is about the influence of the peer group, we found that the peer group among Latinas played a very small role in the suicide attempt, which is different from what the literature has shown for other groups where the peer group is more salient in the reason for the suicide attempt. So that's the answer to that question. And also, we think that when it comes to these interventions, when we talk about parenting interventions and their children's acculturation and then the adolescent development, we promote the idea of separate groups for parents and children, because the conversations are going to be very different about understanding your child's development, understanding, having parents understand why their child is doing what they're doing, because they may not have studied. And as you saw in our data, most of the parents had less than a high school education, and they need to understand why their child is doing what they're doing. And so to normalize the experience, we also need to work with the child on the other side individually so they can understand themselves, but understand why their immigrant parents, for the most part, are asking them to do or insisting that they behave a certain way. And of course, getting at the emotional vulnerability. Next slide. I'm aware I'm running out of time, and I want to make sure I leave time for some questions. To me, the best therapeutic approaches, if we're going to do prevention, we should start in the middle school period. And that's when we can have the parents in separate groups from the children. Youth groups, boys and girls, whether mixed or separate, are important. So again, we can get back to what you're experiencing as an adolescent and how is that clashing with your parents at home. But also in those, to help the child understand why their parents are the way they are. Because the parents may be operating from a cultural system that's based in their cultures and countries of origin. Ideas and behaviors that don't work when their children are acculturating to the mainstream and causing conflicts, whether at home or the child's conflict with the outside world and the performance in that outside world. And I say the same about parents groups so that they can understand their children, themselves, and their children's change. As one mother told me, there are two adolescences here. It was my adolescence back in Mexico and my children's adolescence here in the United States. Those are two very different adolescent experiences. And so that's important for parent families to understand, that it's not one and the same, that your child is not growing up the same way you did. There is utility for individual therapy for the adolescent, but I think it needs to start first with some recognition of the importance of the family involvement, parental involvement in particular, so that they can too be involved. Research has shown that, at least among Puerto Rican youth and Mexican youth, they will expect that the parents are involved in the therapy in some form or other, whether it is directly in sessions or parental counseling by the therapist. And then, again, going back to building at cohesiveness and adaptability, and the process of helping engage families in communication, we need to think about family-oriented prevention programs and family therapy, where they can take perspective of one another. The adolescent can get into her parents' shoes. The parents can get into their child's shoes. Many of these parents have lost their way. Families have lost their way. So I think, using narratives and storytelling, re-engaging families in rituals that added to their cohesiveness, that added to their identity as family, are very vital to any of the approaches that we take. Next slide. Implications for parents. It gets back to, asking parents, how are you handling your daughter's development and growth? How far apart or near do you feel with your daughter? Does she agree with you or not? This goes back to that issue of reciprocity and mutuality. How well do you know what your daughter's facing at school and at home and in the everyday world? Parents will give you opinions and ideas about what's shown on TV and how much clothing the people on TV wear, and every sex scene that appears in a movie and how that's disturbing to them. That might be a common event for a child, an American teenager watching even evening television, and to ask about how the crisis or the arguments have escalated over time, to begin to determine if there is indeed some danger of a suicide attempt, and to let them know that help is available, seek it, use it, and there's no stigma attached to seeking mental health services for their daughters or for themselves. Next slide. And I'll stop there and answer questions if we have time.
Thank you, Dr. Zayas. Yes, we have time for a few questions. So the first one, okay. You spoke about impulsivity as a state and as a trait. How can a clinician differentiate if it is a state or a trait, or what questions do you recommend someone, or what information may be useful to differentiate between the two?
I think, frankly, I'm not sure if there's any scales out there. I do know that there is a state trait anxiety scale out there. But I think we can, if the child's history, if you're collecting a social history on the child, you're going to find out if this is, if they tend to be impulsive and they've always been impulsive, either through their stories or what their parents tell you, or if they become impulsive only under certain circumstances. So the first one would be the trait. This has been a lifelong pattern of the child just being impulsive, and they will act and they will say things impulsively, or whether it occurs in moments, in states that they're in. So a parent could tell you, whenever there are certain people around, or too many people around, or when she's idle or he's idle, that's when I notice the impulsivity. That gives you a sense of that momentary a state versus the trait, which exists longer. Perhaps other clinicians might be able to make some recommendations on scales or even questions that they can ask. But thank you for that question.
Okay, thank you. How do you think generational issues impact young Latinas who may not feel connected to their Latina identity?
Whoa, that is a very good question. That the study that we conducted, and the girls mostly that I've worked with have been girls who are either one or two generations removed from immigration. So they're still more influenced by the culture of the past. Beyond that, by the time the parents themselves are acculturated and they have daughters, some of that may, some of the remnants, if you will, of the original culture might still be around, and it might affect them. But it's a good question insofar as now we've got to look, to what degree does immigration and acculturation really fit in? Because chances are by the fourth generation, they're much more acculturated, and we may have to think differently. And I'm sorry I can't answer that, kind of more precisely, but the person who posed that question is posing a very good one, and it's research that we've got to do to understand differences generationally among Latinas. Because if you look at those national rates, we're not distinguishing between first generation, second generation, third or fourth generation Latinas. They're just identifying themselves as Latinas or Hispanics, and they're reporting the suicide attempt. So, questioner, please consider doing a PhD dissertation on that.
Okay, thank you. I have another question. Did family structure have any significant relationship with suicide attempts, meaning single parents versus both parents in the household?
Great question, and I have an answer for you that came out of our study. We found that it didn't matter whether the mother was a single mom or as a couple, whether father mother or same-sex couple. What we did find was interesting, that some intact families and single mothers had daughters who would attempt suicide, and we had single moms and intact families that had no suicide attempt history in their daughters' attempt. What was most interesting, though, is that we found that among the single mothers whose daughters did not attempt suicide, the likelihood of them working outside of the home was greater. That is, those moms were engaged in the world outside of home, and so they weren't reliant on their children and their immediate community as the source of their support. The other thing that did for those moms, especially those who were less acculturated, is that they were able to learn new ways of dealing with their teenagers at home, because they heard how other people at the office were saying, oh, my teenager, that's this, that, and here's how I handled it. So the mom is bringing home, by being engaged in that, kind of meso system out there, bringing back to the micro system some ideas about how to deal with their children. And that accounted for the moms, the single moms, and actually even the intact families who had girls who did not attempt suicide. So maternal employment was an important one. And it may be that it also models, for the girl, the importance of autonomy and independence and managing that well.
Thank you. Okay, so we have time for one more question. How do you talk to Latino families who have lost someone to suicide when they still stigmatize mental health and depression?
Wow. It's a slow going. I think that engaging that family, and we do know that immediately after a suicide, a death by suicide, it's a huge crisis. There's guilt. There's, we could have, what did I do wrong? Or I missed the cues that he or she was giving me. And I think we have to wait till that is settled more before we try to engage them. But it typically will take one member of the family to step up. I think going to the family and saying, come on in, let's talk, you're not likely to get them. But I think if you get one person in who can then bring another, then you might be able to bring the person along and see that it's not about your mental illness, it's about the feelings that you're experiencing and understanding why your loved one took her or his life. I hope that helps. There may be other experts who know far more about this than I do.
Thank you so much. We have a few more questions, but we don't have enough time to answer them. So thank you, Dr. Zayas, and thank you to our participants. Thank you for taking the time to connect with us and participate in this webinar. I want to let you know that we're working with Dr. Zayas on a curriculum on suicidal behaviors among Latinos. So we will have a training available for clinicians to learn more about this subject in the near future. So maybe we can go to your state and offer a training over there. So as you leave today's webinar, you'll be redirected to complete a brief survey. We appreciate you taking the time to complete the survey, as this will allow us to continue to do the work that we do. So thank you, everybody.
Thank you very much.